Hello, all, and good evening, but also good day to everyone. I hope you had a wonderful day and are again ready to learn a bit more on our topic today, as we will be talking about primary ovarian insufficiency. And we have another special guest. Some of you might already know Dr. Uliana Dorofeyeva is with us tonight. She is right now in Kiev. So, hello to Dr. Uliana. Hello to Kiev. How are you feeling tonight? Dr. Liana, just let me know if you can hear me. And please let me know that anyone else can hear me just to make sure, okay? And I think, okay, Dr. Liana, are you there?
Yes, I'm here,
Okay,
dear Carolina. Thank you.
that's good. Thank you. I was worried for a second because I didn't hear you, but all is good. So no worries. You are right with us. So thank you a lot for joining our event tonight, but also for supporting our if all of our events, because you don't know it yet, perhaps, but Dr. Liana will be back with some more webinars this year. So we are very excited to have you on board. And let me just say that, of course, my IVF Fences is now part of European Fertility Society. And as you know, we are simply here because we want to educate you, support you, help you out as much as we can. And we just want to give you an opportunity to ask your own questions, because I'm sure you have plenty of questions. And as always, you will have a chance to ask your questions tonight as well. And we will start with Dr. Uliana's presentation on our topic, and afterwards it will be time for your questions. Okay, so you can go ahead and type them right now or later on, of course, up to you. And yeah, just want to also mention that Dr. Uliana, she is the director of international cooperations at IVMED, but she is also the medical director at OVOGENE Egg Donor Bank. And it's it's really great to have you back with us, Dr. Uliana. And are you ready to start with your presentation?
Thank you, dear Carolina. Yes, I'm ready to start, and I would like to congratulate you and your team that you've started the European Society. And again and again, I'm saying, and this is from the whole my heart, that you're doing a great job. And I'm always happy to join your initiatives. And tonight we are going to talk about the primary ovarian insufficiency. You know that this topic will be related also to the options of the fertility assessment and how every woman who is facing the diagnosis can deal and can reach the goal of the delivering a baby, getting pregnant, and being happy and healthy the whole entire life. And this is a long-term goal, of course, for all of us, and specifically for us being an IVF specialists. So we are starting. Thank you, Carolina, for introduction. We are talking today for fertility assessment for the patients with the primary ovarian insufficiency. And before we start talking about the specific topic, I would like to address, as mainly you are patients here, so I would like to talk again about the goals of reproduction for me, for our team. This is how we act for every individual patient who is reaching us for the fertility assessment, for the treatment, for the advices. So our main goal is to achieve pregnancy as soon as possible as patient requires. Sometimes we can consider this is already too late, and this is happening more and more now because women are deciding to have babies a little bit earlier, later than usually, and we face situations with of our age, advanced maternal age, with the lower quality of the oocytes, but still there are options, there are treatment possibilities, and we are ready to work on this. Another goal is to maximize success rate for the first initial cycle for each patient. Again, we know that many patients has already many negative outcomes before, but also we need to think, we need to analyze, we need to find the best strategy, and everything is possible also to reach the pregnancy still with the first attempt with the new treatment strategy, with the new doctor, with the new clinic, with the second opinion, with the additional techniques and technologies. To reduce multiple pregnancies, and we absolutely clearly consider that this is unused risks for getting pregnant, to have multiple pregnancies. If we may avoid this, and now we know the strategies how to avoid this and how to deliver a single healthy baby in a single pregnancy, single cycle, this is the best strategy. We need to guarantee, and we do guarantee, safety in IVF, and we are willing to help as many patients as possible. If we may, also to reduce the risks, the costs, to understand the low limits and offer something what is not offered in different countries, to use the most effective techniques and technologies. So what is the premature ovarian insufficiency? This is a clinical syndrome defined by loss of ovarian activity before the age of 40. It characterized by menstrual disturbance, amenorrhea or oligomenorrhea with raised gonadotropins and low estrogen. Probably we all know, but I will repeat that the maximum number of the primordial follicles, and this is our, let's say, bank account, which we will be using, we women will be using through our entire life and through our fertility period, since the puberty until the menopause, and the maximum number of those follicles is during our antenatal growth. And we are given with this certain number of follicles in the ovaries since we are in our puberty. And during the fertile period, we are using between 400 to 500 oocytes, and all the others, they are in the process of atresia. Unfortunately, if we are not using the options of the fertility preservation, if we are not having the stimulation protocols to preserve our fertility, we are losing 99.9% of all our oocytes. Every cycle, certain number of follicles is recruited. One will be grown until the full maturation to be ovulated. And all the others, they are just destroyed in the end of the cycle, and never ever we will be able to use them. The possible mechanisms of the premature ovarian insufficiency, they are different according to the stages of the folliculogenesis. This can be caused, and mainly this is the cause of the genetic mutations, that the number of the primordial follicles is reduced. It can be atresia depletion, that more and more, and this process is much faster comparison to the regular process, that the atresia is faster and in the huge volume, or altered follicular maturation. So once we are talking about ovarian insufficiency, we are talking about premature ovarian failure, that there is non-functioning ovary and there is no ovum production. This syndrome, it was used to be called by different names, as the primary ovarian insufficiency, ovarian failure, gonadal dysgenesis, premature menopause or early menopause, hypergonadotropic hypogonadism, ovarian dysgenesis, etc. But we all agreed, all scientists, and this is important to know also for the patients, that in the guidelines for the management of the women with premature ovarian insufficiencies in all countries, this is recommendation of European Society and the Menopausal Society, etc. We need to call this diagnosis of premature ovarian insufficiency. This is how we divide and when we expect the menopause to come in the normal age range. It is between 45 to 55 years old. It's different for different women, but everything what is the menopause and the syndromes which are starting in the age before 40, this is great that it's only 1%. From all the population in the whole world, this is not the huge figure, but still in the recent decades, We see more and more teenagers with their diminished ovarian reserve. We see more and more young women, even if they are coming just for the gynecological assessment to our clinics, they already have low IMH. They have only few follicles. They look their ovaries and their follicles, and their potential for fertility is already diminished. This is not as we usually we saw older women with the diminished ovarian reserve, with low IMH, with high FSH, but we see this more and more for young women. So the etiology and the causes of the premature ovarian insufficiency, this can be spontaneous or induced. Spontaneous, still for many cases, we call them idiopathic, that we don't know the cause, specific cause for this specific woman of this syndrome. Quite many cases are genetically linked with the X chromosome, the monosomy of the X0 Turner syndrome, trisomia, deletions, translocations, fragile X, FMR1 gene mutation, autoimmune ovarian damage, infections, or iatrogenic. And also the fact that the cancer treatment is more and more effective and more cancer survivals are our patients. They very often, or most of them, they face the syndromes of premature ovarian insufficiency after bilateral oophorectomy, ovarian cystectomies, chemotherapy, radiation, pelvis vessels embolization, or also the environmental toxins may affect this syndrome. So the causes you may see still idiopathic is quite big amount and the percentage of those cases, but scientists are working on this, and there are many other genetic mutations which are indicated in these syndromes as well. Premature ovarian failure main symptoms are irregular menstrual periods, amenorrhea or period absence, hot flashes, night sweats, insomnia, vaginal dryness, decreased libido, painful intercourses, and of course, infertility. In order to test our patients, first is the genetic or chromosomal mutation, so we need to recommend karyotyping to be done for diagnosis of Turner syndrome, test for Y chromosomal material, fragile X, hormonal tests such as FSH, IMH, FMR1, TTH, endocrine profile, and adrenal glands activities. Also, if we are facing a relative of women with the fragile X mutation, they should be offered the genetic counseling and testing. And relatives of women with non-iatrogenic premature ovarian insufficiency who are concerned about their risks for developing premature ovarian insufficiency should be informed that currently there is no proven predictive test to identify women that will develop premature ovarian insufficiency unless the mutation is known to be related to POI and was detected. There are no established POI preventing measurements. There is an option of fertility preservation, and it looks like a promising option, but still the studies and the practical use is very limited, because this is very important, and this is a key message to perform a timely diagnosis of premature ovarian insufficiency. And quite often we diagnose too late. And to diagnose timely, sooner we make the diagnosis, sooner we can get on with the treatment which will maintain quality of life and well-being and the long-term health for this patient, and also the decisions for the fertility, further fertility treatment. The potential risk of earlier menopause should be taken into account when planning the family. Also, if we have a patient who is diagnosed with the premature ovarian insufficiency, we need to remember it, and we need to think not only about fertility, but also about bone health, cardiovascular risks, psychological problems, etc. The menopausal hormone replacement therapy for management of premature ovarian insufficiency, which is recommended. This is estrogen, micronized progesterone, combined estrogen and progesterone contraceptive pills, and testosterone if there is a need. Success rates for those patients who are diagnosed with the premature ovarian insufficiency, if we still can see some follicles, we will of course consider the treatment regimen for that patient and will try to get as high as possible probability of having genetically related babies for those patients. However, very often these are patients who need to be recommended oocyte donation as the only effective fertility treatment option in order to get pregnant. And once we are using oocyte donation, I believe that everyone already knows that oocyte donation is very effective treatment option in a good centers, in a good clinics, who knows and who treat oocyte donation well, both from the perspective of the oocyte donor and the management inside the clinic, and also the patient perspective. We always need to think about 60% and more, and we will talk about additional options which can bring us to the higher efficiency of the oocyte donation. But for this woman, they can be pregnant. They will be pregnant if they will be recommended the right strategy. So for oocyte donation, very important, not only morphological evaluation of the materials which is received, but also the genetic evaluation. And this is already possible, and this is done in our practical almost every day. But also in terms of the management for the patient, it should be easy, the communication between the coordinator and the patient in order to select the best donor, as this is also psychological thing, which is for premature ovarian insufficiency. Those patients, they are not ready to hear this solution in comparison to those who already are facing advanced maternal age and who tried already several IVF treatment cycles with the low oocyte or embryo quality, and they need a solution. So those younger women, if they are hearing this for the first time, they are not ready. So the management of and the transparent guarantees and the compensation scheme is, if needed, donor selection and communication is very, very important. Of course, all donors should be fully screened. The all embryological facilities, if we are, for example, if we are transferring biological materials, because in these specific cases of the COVID, there is an option not to travel patient, but to stay in the home country and to arrange with both clinics or the oocyte bank the fact that the materials can be brought to your location and the fully successful treatment might be performed. This is the practical experience where oocyte donor oocytes were shipped from Ukraine to the destinations which are mentioned here, and this was absolutely safety and very effective. And the communication was performed between two clinics, and patient, of course, was involved as well. What about the oocyte quality? We know that the poor oocyte quality for those patients which still are producing some oocytes, even if they are diagnosed with the premature ovarian insufficiency or they are facing the advanced maternal age and they are willing to have treatment using their own oocytes. So the poor oocyte quality is one of the main causes for repeated failures in assisted reproductive. And this quality of the oocytes is mainly determined by the small organelles, which we call mitochondria, and they are energy suppliers of the cells. Together with all the other factors, they are presented in the cytoplasm of the oocyte. And with the age, we can see that the numbers of the mitochondria is decreased. There are morphological changes inside of them. There are increased mitochondrial DNA deletions in the mitochondrial DNA, and also the function of the cell is decreasing. So age-related changes in oocyte mitochondria are leading us into the lower IVF success rate, lower fertilization, higher aneuploidy rates. Still, oocyte donation nowadays can have alternative. And this alternative is this fact that mitochondria degeneration will decrease women's chances of getting pregnant. Age of egg, the mitochondria get run down. They start to get mutation in their DNA, and that lack of energy doesn't allow embryo to sustain fertilization. In this case, if we can solve the mitochondrial degeneration, we will have chance to repair nuclear function inside of the oocytes. Also, each couple have a social and genetic right to carry up their own genes during the pregnancy. And this still will be physiological and ethical thoughts which are not considering from specialists, but they are considered by the patients themselves. So those alternatives are spindle and pronuclear transfer. This is what we call three-parent babies, which is already used in several countries in the world. Still, I know the discussions, this is still experimental treatment. However, we all should remember that a little bit more than 40 years ago, IVF in general was fully experimental. And any baby before 45 years in the past were born using those techniques. So this is all we need to think about the future. So the spindle has very important role for the cell division and for the genetical potential of the oocyte, and this helps the cell chromosomes to be shared equally inside the cell. This shared chromosomal material is happening because of the spindle. We can determine the spindle only using the special software and polarized system on the microscope, and also this should be embryology team which will be specially trained for this process and further techniques. The spindle transfer is the replacement of the entire cytoplasma of the poor quality oocytes. This procedure is based on transferring the spindle, which contains the genetic material of the egg from the affected woman, into the donor oocyte with the healthy cytoplasma, which had their spindle removed before that procedure. And the eggs resulting from the procedure with the repaired cytoplasma can then be inseminated by conventional ICSI with the sperma of the patient partner, giving the intended parents the chance of having a child genetically related to them. Advantages of the spindle transfer is the fact that it will give families affected by serious mitochondrial diseases a chance of having healthy children free of the devastating and often life-limited disease. And this is additional option into like the medically related treatment, not only the fact that we are helping those women who are facing the advanced maternal age and the poor quality of the oocytes and the embryos. It's already tested, and there are already children born from these techniques. This technique, in comparison to the pronuclear transfer, is less mechanical and morphological. It's easier from terms of the embryological perspective. The pronuclear transfer consists of performing in vitro fertilization using the oocytes of the affected woman, those mitochondrial contained mutant mitochondrial DNA, and the sperm of the future father, and subsequent extraction of the pronuclear on day one of the development, leaving behind most of the mutated mitochondria. These pronuclei are transferred into the enucleated zygote from the healthy mitochondria. So still, two oocytes are fertilized, both checked fertilization on day one, and healthy pronuclear are transferred into the healthy cytoplasma. So by doing this, there is no risk of the fertilization because transfer already between the zygotes, better blastocyst outcome. Also, this will help to treat the serious mitochondrial disease. And this technique and mechanical micromanipulation requesting already a more experienced embryologist and special cultivation method during the micromanipulation. Another issue, and we confirm this by our practical experience every day, that even oocyte donation has already genetically mutated oocytes. And from our practical experience, we checked more than 2,000 oocytes. We faced 28% of those oocytes which are genetically aneuploid, meaning the full cohort of morphologically assessed oocytes from the young women which are fertile, because in Ukraine all women are absolutely fertile, they have their own healthy child, and we still face 28% of aneuploid oocytes. And of course, we know that with the increased age of the patient, this abnormality, percentage of the genetic abnormalities also increased. That's why oocyte NGS testing and the genetic testing of the blastocyst is so much recommended for predictive, to be absolutely clear and to understand how we are expecting this treatment to result. If we are transferring oocyte, which is not, if we are fertilizing oocyte, which we don't know the genetic status, or if we are transferring embryo, which is also not checked specifically for the patient who is over 40 years old and she was lucky to get the blastocyst, the probability of this blastocyst to be employed is really very low. So by transferring this, we are just giving a chance, but this chance will be very limited. And if we will do maximum genetic evaluation of the materials which we are going to use for the implantation of the patient, we would be very clear with ourselves, clear with the patient, transparent, and we will maximize the chances for the successful implantation for every patient. So the unique feature of the female gamete is that the polar bodies can provide beneficial information about the genetic background of the oocyte without potentially destroying the cell. Polar body biopsy has been applied in pre-implantation genetic diagnosis to detect chromosomal and genetic abnormalities that might be inherited by the offspring. So by doing the polar body testing, this is a big advantage to avoid mitochondrial mutation risks and also to make sure that this is a euploid oocyte and we are going to fertilize euploid oocyte. And the advantage of polar body NGS testing from the patient perspective is that the fact that oocyte donation mostly bring financial responsibilities for the patient, and each oocyte looks as a potential embryo. And this is how it should be. Euploid potential oocyte have big chance to achieve good quality euploid blastocyst. Most of the egg donation programs in different clinics does not require NGS or PGD testing before embryo transfer. Euploid oocyte potential will give the best option to the patient. And of course, this is not only the fact that we need to check the quality of the blastocyst and we need to maximize it to be genetically healthy and with the highest quality. Also, we are checking endometrial thickness, we are checking endometrial receptivity, we are checking the status of endocrine function of the body, immune response for each patient, and also the endometrial receptivity, as I said. Another option which can be recommended for those patients with the primary ovarian insufficiency, if they are still producing few oocytes, or for patients in their advanced maternal age, this is combined oocyte donation. Once we stimulate a patient, trying to get as many oocytes as possible, giving the last chance to try, but also in a day of the oocyte pickup, we saw we warm or vitrified oocytes from the donor, which is selected by the patient, and we fertilize both groups of the oocyte from the woman, from the patient, and from the donor with the husband's sperm. We cultivate them separately, and on the day of the blastocyst, we consider the quality of the blastocyst, their potential, and we discuss with the patient which materials should be transferred. Also, we recommend to do PGS testing for many patients. This is, of course, a decision of the patient, but still we see the difference between the clinical pregnancy and the total outcomes. So, and quite often for women with the premature ovarian insufficiency and in advanced maternal age, we do not see high quality blastocyst, or we have any blastocyst once we perform the cultivation. So, and we need to cancel the embryo transfer. In this case of the combined oocyte donation, we are not canceling the treatment, and we are ending up with the embryo transfer and very in high probability with the clinical pregnancies. So to conclude, there are different treatment options which may be recommended to in IVF to achieve a goal of the parenthood. Second opinion needs to be recommended due to the specific limits and the techniques which are not used in every clinic, in every location. The most effective treatment for patients with the primary ovarian insufficiency and advanced maternal age is oocyte donation. Experimental treatments available in IVF are effective and may be accepted widely in the future. And if you are still listening this webinar, and you haven't tried all mentioned above, you should keep trying, and we are happy to help you in that. Thank you for listening. Thank you for attention, and I'm happy to answer all your questions you have.
Dr. Uliana, thank you so much indeed. Lots of information, that's for sure, but that's what we are here for. So thank you a lot. As always, thorough presentation. Thank you so much for that, for sure. And yes, you are very right. There are a few questions left, but if you haven't asked your questions yet, you know what to do. Just go ahead and type it in, and Dr. Uliana will be happy to answer, I'm sure. And let's have a look, okay? Let's have a look at the very first question that we've got right here. Just give me a second. So the first question is, how many follicles is considered good potential at the age of 40?
Thank you, Ella. It's a very good question. I like to talk to all our patients, and we always are very transparent, as I said, and we rely into the statistical data. However, I like those patients which are out of statistics, and still we have a lot of questions, a lot of patients which are out. Those patients who are getting naturally pregnant after their 40s, and they are still existing. But coming, I just saw today one of those, and I was really happy. And I remember that I'm going to talk this evening and also rely to the statistics. But I need to mention that everything is possible, and all depends on the patient, on the beliefs, on the strategies, etc. So I would consider also there is IMH and there is antral follicle count, and we need to talk about both. So I would like to see number of antral follicles over 5 for patient at her age of over 40. Without being like, of course, I would say 15 is the best. However, we need to understand something what is still close to the reality. And also, I would consider IMH. As we know, the IMH, this is still a factor or the hormone which will show us the potential of how many we are going to receive if we will do some additional activities. For example, dual stimulation, or if we would decide to have some pre-treatment strategies for the next treatment cycle, or if we would increase the gonadotropin levels. So for me, it's both. to see antral follicles over 5 in the age of 40 and to see the reasonable number of the IMH, which in this case would be over 0.5, and if more, the better. Okay, so we have 5 follicles in, no, in not in the one ovary. If it would be 5 in one ovary and 5 in another ovary, it would be 10 total, so it would be even best. However, we need to understand that we can see PCOS patients who were PCOS diagnosed once they were young. And those patients probably will have 5 and 5 in their age of 40. However, still we need to understand the issue with the ovarian age and the female age and the quality. So we need to not just to receive oocytes, but to make sure that we received euploid oocytes or make sure that we received euploid blastocysts, and this will be the winning situation.
Excellent. Thank you so much for a great question indeed, and of course for your assistance. And as you can see, there is a thank you from our patient right here for you. And actually, sorry, Ella has another question. So why there is different number of follicles in each ovary, and if that affects quality?
We need to understand, as I started from the numbers of primordial follicles in both ovaries, ovaries have their volume and they are round, and also they have cortex. In the cortex, there is a maximum number of the follicles, and it always, like, it depends on the volume of the organ. Also, it depends, for example, like we could have adenomyosis, endometriosis, we could have some surgeries on one of the ovaries before, so this, or not even in the ovary. For example, we can have appendectomy, and through the laparoscopic treatment, anyhow ovary can be somehow affected, so this ovary starts to respond slower. So there are many factors which affect the number of the follicles, but this is not a crucial thing. For IVF doctor, the crucial thing is the total number of the follicles in both ovaries. We never divide them into one right and left. We only can do this in case, for example, we are thinking about IUI to be done for young women for the male factor of infertility, and in case one tube is blocked. So of course we would consider the ovary on the side where the tube is okay. But if we are talking about IVF treatment, there is no question about this.
Wonderful. Thank you so much indeed for yet another explanation. Okay. Okay, let's have a look at the next question in regards to your presentation. Okay, so Sayuri has added, so hopefully I heard this right. Can we use donor without having to go to Ukraine?
Yes, yes. If you've heard my previous webinars, I'm talking a lot about options of traveling the biological materials. Actually, this is my practical experience started back in 2008. Once I was coordinating the first international program in Ukraine on export of biological materials. We imported sperm from the country where oocyte donation is legal. We did fertilization. We did full cycle of the donor, fertilization of the oocyte with the male sperm, which was imported, and we sent embryos back into the country where they were implanted. So neither men, neither women were traveling, just the medical couriers and the doctors who were checking all the processes in both clinics. So there is a possibility not to travel to Ukraine, but to receive the biological material into your home country. The only rule is that this country should be may officially use oocyte donation. Such countries as Ireland, UK, Austria, Poland, Latin America, Canada, US, they all can receive materials from other countries, from outside banking, and this is all doable. And for these specific times, I always was for this, because while seeing the patients in our clinic, I like to communicate with all patients and to treat all. However, I understand if I will treat 30, 50, 100 patients per month, or if we will establish the cooperation with the center, we would definitely help more patients by doing this transportation of the materials. And we have countries where many children were born already using Ukrainian oocyte donors. So if you need to get more information on this, you can contact me later and we can discuss.
Wonderful. Thank you so much for confirming that. And sorry, just so you know, of course, I have sent you a link. If you click on that, you will find previous webinars with Dr. Uliana, so you can check it out as well. Okay, and let's have a look at the. I'm sorry, the Sayuri has added something, so let me just go straight to this one. So this is fabulous. I'm seriously considering egg donation. I'm 40, Habe is 43. Thank you. I will reach out. Okay, thank you so
Yeah,
much.
thank you.
And let's have a look at the next question. How precise is the genetic analysis of the polar body? I have heard the results are not relevant for conclusion of euploidy of the oocyte.
It's great question. We already passed through these many years of the discussion related to the fact, should we do the NGS testing of the blastocyst, should we do PGS, PGD, what to do with the mosaic embryos. Does it mean if this is mosaic we should not use it, or if we would take the biopsy from another piece of the zona pellucida, if that would be different, etc. But still more scientists and also one laboratory would give one result, and if you would compare, this will give another result, and this all depends on the quality of the methodology, of the people, the machines, etc. However, the group decision, the scientific decision, the recommendations which are given if we have a medical indications. For example, age is a medical indication for genetic testing of the embryo of the blastocyst. If we recommend this to the patient, and this is a patient decision or patient decision together with the doctor, it is recommended to do this. And for sure, we have significantly statistical difference in transferring and results once transferring embryos genetically tested and not tested. Both in terms of the proper implantation, in terms of the early miscarriages, in terms of the potential of the genetic mutations to be founded in the second trimester of the pregnancy, etc. So still, I believe, as always, methods can be improved, but we worked with the proven laboratory, which is selected, and we worked with that laboratory for years for our blastocyst biopsy and the NGS testing, which we do for blastocyst, and we have no concerns regarding the quality of this, and we do the same NGS testing of the oocyte there as well. So it's not mandatory. We need to understand. Of course, we may recommend to use just 10 oocytes which are not tested, and we would expect to have 70% blastulation or 60% blastulation if this is a good proven donor. But if we would use NGS tested oocyte, this figure will be even higher.
And excellent. Again, thank you so much for yet another great question. And as you can see, what can I say else than show you this? Thanks so much, Dr. Liana. Your knowledge is amazing. Thank you. And okay, let me go to the next question. So, is there anything one could do to improve recruitment and growing of follicles to get pregnant naturally?
Annalie, I need to get more information. If you are uh, in your age, before I'm thinking now to say 35 or 40, just because I saw that wonderful, positive, pregnant woman in her age of 42 with the natural conception who was prepared for the IVF starting the next cycle. So, still, this is out of the statistic. But if you, let's say in the middle, if you are less than 38, you have proper ovarian reserve, you have great sperm quality of your husband, you have your tubes are normal, you have no endometriosis, what else? Endocrine function is okay, like TSH is fine, there is no issues with the immune response, etc. So you may consider improving recruitment by adding additional supplements like vitamin D, like coenzyme Q10, like folic acid, like some additional supplements. But again, if we are talking about science, there is no significant statistics difference for that something will happen different, that your natural conception will be successful and how soon. Also, there is a question: how long have you lived with this infertility? Like probably there is some other factor which is not working to let you get pregnant. So um, frankly speaking, I do recommend some additional supplements and I have schemes, but I'm more considering this as a psychological additional good job which is done by responsibility of the woman, that she's doing something in order to improve her recruitment and growing the follicles. However, I don't want to tell you that something specific will work because there is no proof for this.
Understood, of course. Thank you once more for that. Okay, I'm just looking, and there is another question from Anelli. Okay, for now at least, it seems that might be our last question. But of course, if you have any left, you know what to do. Just go ahead and type those in. Um, and let me just go with this. So, what is your opinion about red light therapy or near infrared therapy to improve ovarian mitochondrial function? Could it have any influence?
Frankly speaking, I had no experience using that yet. Um, if if there is something like this, I will be happy to get more information about that, and I will read for sure. But of course, this will be something which is not confirmed. But again, most of those treatment options which I was referring to in my presentations, they are um, not approved for being used regularly and everywhere. So I believe that this is something what needs to be considered. However, we need to understand the physiology. If we are having mutations on the level of mitochondrial DNAs, I'm not sure that the red light therapy can help DNA to be working again as well as it was before. So this is something what is there are some changes which we cannot change back, let's say. So I'm not sure about the efficiency of this therapy. No experience in that. Sorry.
Of course, understood perfectly. Thank you so much still for, of course, for your question, and Dr. Liana for your help. Okay, and let me just wait a bit. Let me have a look. At least for now, I do not see any more questions. However, someone is typing. So as always, let's have a look and see if we have another question. If not, we will simply be finishing slowly. But of course, don't miss the chance to ask the question. And yes, there is a thank you from Nelly.
Mhm.
Thank
Thank
you
you,
about
Anna.
good presentation. And let me have a look. Okay. And just so you know, of course, if you don't know yet at least what to ask, remember that if you click on the link that I have sent a few minutes ago, then of course you will be able to simply ask your questions using our using our um, short form there. Sorry, and of course, Dr. Liana will be able to get back to you as well. And someone is typing again, so let me have a look if we have another question. And in the meantime, I can also show you that there were other people that commented your presentation. Lovely presentation. Thank you very much, Doctor, for the information. And well, let's have a look. Okay.
Mhm.
Someone again is typing. I definitely want to make sure that we answered all of your questions. Okay.
Until we are waiting for the result, I would like just to share the experience of the combined oocyte donation. This is also an amazing story. I like to tell to all of the patients who consider or think what to do or what should be the next step. So there was a patient of 43 years old. She was Ukrainian, but she changed her place of living into Italy, and she came to us with her new husband. And quite often we know that this is a second family needs to have another child, specifically the male partner. He had any children before. So she said, I know the issue of 43 years old. I understand my ovarian age, and she had just 2 follicles, and she was stimulated with the average dose of 2 to 5 gonadotropin every day, and we received 1 mature oocyte, 1 degenerated or immature, I do not remember, and we fertilized that 1 oocyte, but we offered her to use also donor oocyte in this specific case, because 1 oocyte, we don't know how it will be fertilized, what would be the embryo development. We are recommending to grow until blastocyst stage. Of course, the probability was very, very limited. So we recommended her to use 4 additional donor oocytes, and we fertilized all 5, 1 from her and 4 from the donor. So we ended up with 1 average quality blastocyst for the patient and 2 high quality and 1 average quality blastocyst from the donor oocytes. And this was a feeling, what to recommend to that patient. But she said, I understand, I would like to transfer only mine. But I understand this is a complicated story to come here to Ukraine, to stay here. I'm already working there, etc., etc. So let's transfer 2. We don't like to transfer 2 in many cases, as we would like to have 1 single pregnancy, single implantation and a delivery. But in this specific case, we decided to transfer 2. So the end of the story was positive beta CG and twin pregnancy, 2 delivered, 2 girls. Of course, we understand that 1 was absolutely related to the family and to the mother, and 1 was from the donor oocyte. But the most important part was when they came in 6 months' time. So those 2 girls were still small. They were breastfeeding only, but the father said, and of course this was a question: are you going to find out who is from your oocyte, who is from the donor oocyte, etc. So the father said, so I am coming into Ukraine, and I know that to eat potato here is a national tradition, and we Italian, we like to eat pasta. So I will wait a little bit until they will be grown up, and I will put them 2 plates. And who would take a potato? I would understand she's Ukrainian fully. And who would eat pasta? We would understand this is from the donor, or the prevalence is mine. So this is very funny story, but this is additional belief into that everything is possible, even if you're 43, even if you received just 1 single oocyte. Sometimes you can listen to the doctor who knows the statistics, because the statistics say we cannot transfer just one oocyte, we should transfer just one embryo, we should transfer two, because the probability will be higher. But still, everything is possible. So,
Amazing. Thank you so much for sharing. This is something that, thank you so much. Definitely, because as you can see, our patients definitely like that story. That is very nice and that's so funny. I couldn't agree more. That's for sure. Thank you so much for also, sharing, because someone has, Vanessa has added actually, and I can only agree. Always uplifting. Thank you so much. And more of those thank yous are coming up. We will be finishing, but definitely want you to see. Thank you very much. You give me hope this evening. And we are also here every single day as well, right? For giving, not only sharing knowledge, but also um for simply uplifting you however we can, right, Dr. Uliana?
yes, absolutely.
Okay, and
Absolutely.
in the meantime, actually, one more question is right here. Okay, let's have a look.
Mhm.
So how is it possible to conserve the quality of the oocytes between 40, 50, or keep it in good quality concerning mitochondrial and permeability of the cells? I would congratulate for the fantastic webinar.
Thank you, Judith. This is very discussable question, and this is a question of the fertility preservation. Fertility preservation is a technique which gives us a potential or possibility to freeze the tissue or the cell. And there is a recommendation, again, based on the statistical data, that we should freeze the preserve the any materials, either the ovarian tissue or the oocyte or the embryos, until the age of 38 for the patient. However, with the NGS testing of the oocyte, and also considering the fact that every patient has a right to try, yeah, so this is more probably ethical question, like, should we recommend patient to go ahead with the treatment, to spend money for the medications, to pay for the procedures, if we know that the probability is very, very low to get good quality materials? However, still, this is a final decision of the patient. And again, going out of the statistics, even if we would preserve one, two oocytes in one cycle of the stimulation for the patient over 40, and then we will have another cycle, and again we will preserve another oocyte or two, we will still have probability to work with that material. There is no possibility to freeze it inside the body, because every cycle we cannot freeze this. Every cycle we are given with the specific number of the follicles, and if we are not using this, we just lose this. That's why we can think about preservation of the materials, but we need to do some actions, meaning this should be stimulation, OPU, and then freezing of either the oocyte or embryo. I would not recommend ovarian tissue in this specific case, of course, but I would consider having stimulation if there is a will like this. Or better to go ahead with the fertilization and embryo transfer, because it's a good time to have a baby between 40 and 50.
All right. Again, thank you so much for yet another interesting question indeed. And of course, Dr. Liana, for your help. And okay, I just put your email address, Dr. Liana. Yes, the one that you had on your presentation. So if anyone would like to get in touch with Dr. Liana, you can use that. Okay, and one more question. Okay, let me just show you. So okay, sorry, it's about your details. So of course you can find
Okay.
the details in the chat section. And yeah, so I only wanted to add that Meg has added, you give me hope this evening. The doctor told me it is not possible for me to get pregnant with my own eggs. But as you said, sometimes nothing
This
is
is
certain.
a, yes, this is a second opinion option or possibilities. So I would never say never. That's why Of course, I don't know all the story and why this was said by the doctor, but I'm happy to check everything, and we will be happy to do everything what is possible, of course.
Wonderful. Thank you so much indeed. And we'll be finishing for tonight. Thank you so much, Dr. Liana. It's always great to have you back. And I'm only, I'm feel very, very happy that I know for sure that you will be back. Okay. Thank you
Thank you,
already.
Carolina.
And so, of course, as you can see, there's one more. Thank you for interesting presentation again, and thank you everyone for spending another evening with us and Dr. Uliana tonight. And I can only wish you to have a lovely evening or day. I'm not sure where you are right now, but yeah, and I simply hope to see you tomorrow. You know that we will be back tomorrow at 8 p.m. with another topic. So if you are free, just go ahead and join us. And just so you know, of course, this has been recorded, so you will be able to find it on our website, My IVF Answers. And if you go to our Facebook or Instagram, you know that there are plenty of more events coming up. So go ahead and sign up if you haven't already. And yeah, that is it for today. Thank you once again, Dr. Liana. Again, have a lovely evening. And
Thank
till
you so
our next
much. It's
webinar.
always a pleasure to join you, and thank you all for staying with us and for all your wonderful questions. And you need to believe. Belief is the most stronger thing we can give to us, firstly to us, and all the people on your way. Situations they will come if you're ready to accept this. So go ahead, and everything will happen.
And that was perfect ending for our great webinar for sure. What can I else add here? Nothing really. Thank you so much. Take care, everyone.
Bye
Bye.
bye.